I'm Dr. Russell Libby, and I welcome you to the world of medicine. If you've lived in Northern Virginia long enough, you've suffered from some kind of respiratory problem. Whether it's virus, flu, we've got some very sick seasons here, the transitions from one season to the next, and all of the kinds of viruses that we have, living in a densely populated area, and of course, if you have kids, forget it. You're destined to have a load of colds in your household. Allergies. Do you know that the Washington area is known as the allergy capital of the United States? With our seasonal variations, all the pollen from the grass, the trees, the weeds, as we go into the fall, the molds, and then of course we have wet and dry through the winter, so we get lots of molds then, but really dust, and people with these perennial allergies, they're miserable all year round. And of course, we have such a densely populated and traffic-ridden area that we have pollution, which causes all kinds of irritant byproducts that really do bug people. If you've had some of these respiratory problems, you're likely to have had some complications from them, whether it's a sinus infection, ear problems, throat problems, tonsils, whatever it might be. You've had your series of issues, and there are so many complications that may affect the way you breathe, the way you sleep, whether you taste, whether you smell, all those kinds of things. Well, we've got a great studio audience today who's going to share some of their issues, their history with us, and help us understand some of the things that they've gone through that have had to deal with the issues relative to their respiratory tract. We've got a great expert, Dr. Robert Bahadori here. He is an ear, nose, and throat surgeon, a specialist. He takes care of both adults and children. He works with Otolaryngology Associates. They have offices in Fairfax, Reston, Loudoun, and Centerville. And I'll tell you, I want to start because I know we've got a really great patient here. You've had problems really with your respiratory tract from time to time, right?
Yes.
You started when you were just a little baby. You remember any of that?
Mm-hmm.
You do? Okay, well, your mom could tell me a little bit more.
Well, when he was born, everything was fine. And when he was about 6 months old, that's when he first started getting the runny nose, the congestion, usually clear, then turning more thick and yellow, which would then turn into an ear infection and eventually go into his lungs. And so he'd end up with pneumonia, bronchiolitis, pneumonitis. And it was a vicious cycle that basically repeated itself every 4 to 6 weeks. And so we're continually going to the pediatrician, getting more antibiotics, taking those, taking another course of antibiotics, waiting 2 to 3 weeks, and then starting the process over again.
So as a baby, you had lots of colds,
Mm-hmm.
and they were worse than most colds would get.
Yes.
And as time went on, he had all those ear infections, but ultimately he had a diagnosis that came out of all that.
Yes. He was 18 months old and had massive pneumonia in both lungs. And while we were in the hospital being treated for that, they, over at Fairfax Hospital, decided to do a sweat test and discovered that he actually had cystic fibrosis.
Right. And cystic fibrosis, it's a very heady diagnosis. It's something that you have to live with. It does change your life a bit. And I'm sure you know how it changes your life pretty darn well. You got to do a lot of medicines. You have to take care of yourself. Really special, right?
Yes.
But I know you're a pretty athletic guy, too.
Mm-hmm.
You play baseball.
Yes.
It's your favorite thing. In fact, right now you guys are heading into the playoffs.
Yes.
All right, your team's going to win?
Maybe, maybe not.
All right, you got some tough competition coming your way. So we'll talk a little bit about the special qualities of cystic fibrosis in just a couple of minutes. But those early respiratory infections, which all kids have, obviously some of them would make you wonder if he was more sick, he'd have pain. Were they painful infections, or was it just sort of the kind of thing where you showed up at the doctor's office because he wasn't getting better or he seemed a little sicker than you were comfortable with?
It was kind of a combination to where he just always seemed a little bit sicker than normal. We kept his bed elevated, so he didn't sleep lying flat from the time that he was about 9 months old. And we had coughing and wheezing and congestion, so we had the warm mist humidifier, the cool mist vaporizer. We used the vapor rubs. We were doing the sinus drops. We were doing the bulb syringe. Pretty much everything that you can read in any one of those books, we tried them all. And finally, almost get the diagnosis of cystic fibrosis was kind of a relief because it kind of put a label on everything that had been going on. And then he was also then later diagnosed with underlying asthma and then the chronic sinusitis.
So we basically have an ENT show with you.
He's an ENT dream.
He is a dream. But I wanted to get a sense for Dr. Bahadori, at least a little bit about ear problems, because they are so common in kids. Give us a little perspective, I guess, on what happens with the ear and why kids get infections.
Sure. Maybe I should bring this poster up first, Russell, so we can go over the anatomy of the ear.
Sure.
And if we look at this, we have the outer ear here, the ear canal, the eardrum, and the three small bones that are in the middle ear. And then it goes to our hearing organ called the cochlea, and our balance organ is up here. And a lot of people say, I've had an inner ear infection or outer ear. Really, young kids are mostly getting middle ear infection, which is behind the eardrum right here. And the middle ear is connected through the back of the nose to the back of the nose with a eustachian tube. So that's the tube that you hold your nose and pop your ears when you fly or equalize your ears. And in kids, their eustachian tube's more straight, and by around age 7 or 8, it starts tilting down to a 45-degree angle. And when it's straight, it's shorter, it doesn't work as well. Kids don't know how to pop their ears then. They get colds, runny noses, they don't know how to blow their nose, and all that drainage drips down over that eustachian tube and makes them more prone to getting ear infections. Because if this thing doesn't work well, they get a negative pressure in here, and the eardrum gets pulled back, and that's when you and I are on a plane and try to equalize our eardrums and push it back to its normal position. But if they can't do that, it fills up with fluid, and then the fluid is sitting there like a bag of water, and bacteria gets in there and gets the fluid infected. So in a younger kid, where the eustachian tube's smaller, the bacteria could creep up there and get the fluid infected. In a 7 or 8-year-old kid, the fluid may sit there and it doesn't get infected, but it's like putting your fingers in it. They hear, but and hearing goes down. So parents complain or teachers complain that the child's not responding. Other risk factors for ear infections are daycare. Daycare is a big risk factor. If they're around all these other kids with colds and runny noses, they're going to catch it, so they get sick. Family history is a big one. A lot of times one of the parents has had a lot of ear infections when they were younger. Smoking around the child, laying down with a bottle of milk, probably weaning off the pacifier. Those are really and then the winter months are usually worse than the summer months. More colds, runny noses in the winter months.
So usually, of course, as a pediatrician, I'll see lots of ear infections, but typically you will get a history of people coming in when they have young babies with kids who just seem really out of sorts. So they've had a little cold. They don't even have to have much fever, but they won't sleep well. They're in pain. And that, as you describe, is that infection where that pus is pushing against the eardrum, which has lots of nerve fibers that are very sensitive. And of course, the babies don't really know how to communicate that my ear hurts, so they end up coming to the office, and we see that. And we'll often treat them. There are times, though, where as they get older, we'll sometimes not treat ear infections, which of course is something to talk about a little bit too. But what we do see is that usually they'll have ear infections in the first year. I get somewhere like 60% of babies in the first year of life will have an ear infection. And into the second year, 80%. And by 5, they say almost 100% will have had one infection, not necessarily something terribly dramatic. It seems that some don't have the same level of sensitivity as others when they do get them.
That's correct. And once again, you're absolutely right. The eardrum is extremely sensitive. So sometimes, even if the fluid is not infected and they're sitting upright, the child's doing fine, but then the parents complain that as soon as I lay the child down, when the parents want to sleep, that's when the child decides, hey, I can feel the fluid, and it bothers them, and they want to keep the parents awake. So it gets very frustrating.
Right. So when we approach ear infections, the first level of care obviously is one where you make sure you don't have some complicated infection, because sometimes an ear infection is part of a larger type of infection. But the mainstay of treatment for ear infections?
I think first thing is important to realize that even though the infection is here, we think it's just a simple ear infection, right up here is the brain. And 99.9% of the time it won't go there, but if it's your child that has an infection that spreads to the brain, it could be devastating. I remember we published a paper about 7 or 8 years ago that we were explaining our experience at Fairfax Hospital. I had one patient that was in the hospital for 60 days from complications of ear infections, 30 days in the ICU, and that child almost died with seizures every day from complications of ear infections. That is rare. It's uncommon, and fortunately, it doesn't happen that often, but if it's your child, it gets dangerous. So I think the point that you mentioned, when they're younger, they can't explain, and you see a significant amount of pus behind the eardrum, you're more likely to treat it with antibiotics and make sure that you don't see any complications from ear infections. Sometimes the infection can break through the bone back here, the ear gets pushed out, which we call mastoiditis, or sometimes it can go to the brain, which is meningitis. But mostly, with the antibiotics, they will respond. And in Europe, oftentimes they try to not treat as much with antibiotics because if you use too much antibiotics, then we promote a lot of resistant organisms. The bugs are much smarter than we are, and if you use too many antibiotics, then it becomes resistant. So the other approach is to watch the child for 24, 48 hours, just give them some Motrin or Tylenol to manage the pain, and maybe see that child back again, make sure that the fever's not high. Because our body can fight the infection sometimes when we don't need antibiotics all the time. And if you have a dependable family that is willing to come back and have the ears checked, you can make sure that you're on the right path. And if it's looking worse, to start the antibiotics a few days later.
Sure, and when we see patients with ear infections, if they're under 2, we're a little bit more cautious, especially if they're under 1. They'll end up on antibiotics a little bit more easily. And as they get to be towards 2 and they look pretty stable, they don't have a high fever, they seem not to be in a lot of discomfort, we'll often take that wait-and-see attitude, and often it works out quite well. Now, one of the other things we've seen over the last 15 years, but in particular the last 8 or 9 years, are vaccines that help children resist those typical bacteria. Those are Haemophilus influenza.
And the pneumococcal vaccine.
And the pneumococcal vaccine.
And that's been, those are the number 1 and number 2 reasons why people got ear infections or throat infections, and the pneumococcal vaccine has significantly helped with ear infections. We see a lot less ear infections, less likely for kids to need ear tubes these days than a decade ago.
So that is the next question I have. Of course, once they have an infection, they obviously have some predisposition, whether it just be the moment, but as you say, there is heredity there, and it's usually the anatomy that makes them more prone to those recurrent infections. And let's say they keep getting one after another. Is there a threshold at which we start to think we do need the next level of intervention, as you were describing those PE tubes?
Right. The numbers we're looking for when the pediatrician starts sending the patients to us is usually 6 to 8 ear infections in a year. Or if they get sometimes it's just one ear infection, but the fluid doesn't clear up. It just sits there. And initially, the fluid is more watery. But as time goes on, that air escapes out of that fluid, and it becomes very, very thick. Sometimes it becomes as thick as molasses. We call it a glue ear. And the hearing with fresh fluid is more near normal. But as the fluid gets thicker and thicker, the hearing goes down. And the concern is between 0 to 3 years of age. If you're walking around all the time and anything like that, speech and language may be affected. So if they're having fluid behind both ears for 3 months, or if they're getting 6 to 8 ear infections a year, or sometimes just one ear infection, but they're on constant antibiotics. It's just a resistant organism, and the antibiotics is not getting rid of the pus and the fluid. Then we think about ear tubes, the PE tubes, which is just a piece of plastic about the size of a grain of rice that we place in the eardrum, and there's a hole in it. And the hole is equalizing the pressure on the outside and the middle ears. You remove all the fluid, so the hearing immediately goes back to normal, and then that equalization bypasses this whole system here. And these tubes tend to last 6 months to 2 years, and you're hoping that when the tubes fall out, this eustachian tube has tilted a little bit more, and they've grown out of it. And 80% of kids do fine. They don't need another set of tubes, and 20% as soon as the tubes fall out, same problem. Ear infection after ear infection. In those kids, we put the tubes back in.
So those are the issues that we deal with the ear. And I do find that sometimes we have kids who have incredibly sensitive immune systems, and they get extremely sick with the infections, and yet they develop multiple allergies to the antibiotics, and it becomes harder and harder to treat them.
Absolutely, absolutely. One of the concerns is if it's a child that becomes allergic to multiple antibiotics. And the nice thing is with the ear tubes, you can bypass. They can still get ear infections, much less likely, averages maybe 1 in a 6-month period. But if they do, it's not a guessing game.
Right.
You see drainage coming out of the ear. Same way you get a runny nose, you get runny ears. But instead of all these antibiotics by mouth that they can be become allergic to, we use antibiotic ear drops that goes right through the tube to where the infection is, and it clears up the infection much quicker.
And you folks also had to go through another set of infectious experiences. As you were telling me,
I'm sorry.
you had sinus infections too.
Yes.
Do you remember getting a sinus infection? Probably your ears you probably don't remember anymore.
No.
But I'm sure you can remember having a sinus infection.
Yes.
And tell us a little bit about what you experience when you have a sinus infection. Can you tell me a little?
Well, when I was done with the surgery,
Yes.
and my nose, it was all clogged up.
Okay. So that's what you
It was
remember the
hard to
most.
breathe.
You get clogged up
Yeah.
and it's hard to breathe.
And when I went home,
Yes.
I was perfectly fine. And then on the night, after I got home,
Yep.
it just like all clogged up in, like once.
Yeah.
It just like kept on clogging up. Like every minute, it just
Just
kept on
couldn't
going.
breathe. Boy, that must
Yeah.
have been pretty frustrating. So was that after one of the sinus procedures or?
When he was 5, no, 4, they went in to try and flush out his sinuses,
Right.
but because the mucus and everything was so thick and sticky, nothing could come out. And so he ended up needing sinus surgery. He's had it twice. But prior to, basically his maxillary sinuses were 100% clogged up. And so he was congested, he was snoring, he was, waking up in the middle of the night. Just pretty much everything that an adult goes through, he was going through, but in a much smaller area.
Right. And of course, he has those allergies, he has the asthma, and he has the difficult mucus to clear. I guess it's worth a little bit of discussion as to what cystic fibrosis does and what exactly it really is relative to how people experience it.
Yes, cystic fibrosis, really the secretions in the body are much thicker than normal. So the problem is they end up having more lung problems, digestive problems. Really, any fluid in the body is much thicker than normal. So with the sinuses, we have 4 pairs of sinuses, and you got the frontal ones, which are up here. You got the cheek ones, the ones around the eyes, number 3 and 4 here, and then the sphenoid sinus, which is number 12 here. And inside the nose, we have millions of these little hairs down here called cilia, and they're constantly beating back and forth. And as adults, we produce about 1 quart of fluid every single day in our sinuses. It's like a car wash. These little hairs are constantly beating back and forth, and it takes all the secretions towards the back of the nose, and it's a way for the body to get rid of all the environmental pollutants, all the bacteria, all the junk that we breathe in through the air. And then we swallow it, and the acid in the stomach destroys things. But with cystic fibrosis, their secretions are much thicker than normal, and it can't drain properly. This is an adult-sized head, and the opening, for example, for this sinus is about that size, or the cheek sinus, the opening is about that size right there. So it's not very large. So if the secretions are thick, it can't really work themselves out. Or if they have allergies or a cold and the tissues swell up, the openings get blocked, and the sinuses say, I don't care, I want to keep producing my fluid, and the fluid backs up, and that's when they feel the pressure, discomfort, pain in the face. JP here with the CF, also they form benign growths, polyps we call it, in the nose, and that blocks their sinuses too and causes obstruction with their breathing. And then the other function of the sinuses, these sinuses are that the air that you breathe in goes into all these different cavities, and it brings it to the proper temperature and humidity by the time it gets down into the lungs. So a lot of times when this is unhealthy, asthmatics, they notice their lung is not behaving well, or CF patients notice they're having more lung disease. So oftentimes if you can keep the upper part clean, the lower part will behave better.
So there is a pretty remarkable relationship between the immune function. Obviously, if you have allergies, it gives you some chemical mediators that cause irritation. You might touch on that a little bit. And then also, I guess the bacterial populations tend to generate some irritation and some reaction on the body's part on their own.
Right. The allergies play a big role. Most of the patients I have to operate on their sinuses, most of them do have allergies, so we always check their allergies. Small kids like JP, he's a big boy now, but we always want to rule out cystic fibrosis. That's a common reason why they get sinus infections and lung disease. So we always work with an allergist, and we always check their allergies and address the allergies. And that's one of the reasons why with the kids, we always, or adults, we like to use the saline irrigation, which is just we put salt water in here and have the kids irrigate the nose to try to flush whatever it is in the nose that may be irritating, whether it's dust, allergens. Because the testing between 2 to 6 is not very accurate. They may test negative. The parents think they're happy their child's not allergic, and it may show up later. Their immune system is not strong enough to be tested yet. And then we know the bacteria, there's 3 or 4 bacteria that cause a lot of sinus infections, and we address those specific bacteria with the antibiotics we use.
So I know that we have a really neat little segment on how those nose washes happen, but you've been doing them for a long time.
Yes.
And you've gotten pretty comfortable with them.
Mm-hmm.
Yep. You know how to do you do them to yourself, or does mom help?
I do it to myself every day.
And so he's gotten pretty good at it.
Oh, he's amazing.
Yeah. And they really help.
Oh, they truly make a difference. And we've actually found that if we do them right before he goes to bed, then he actually sleeps better at night because everything's kind of all cleared out. And then in the morning, he can do them again.
Right.
Before he heads off to school.
Interesting. So we can see that there are a few different techniques, and we've had some great cooperation in our little video clip to show that.
This is the fish syringe, and when you spray it, it just gives a very fine spray in the nose, okay? And this is the one that you're used to using too, which is just irrigating inside the nose. So why don't you go ahead and use this one first. Here, put your nose in front of the sink, and then spray in there. Good job. And let me have some tissue. Okay, and then she blows her nose really well. Blow your nose really hard. Excellent. And do the other side now. Good. And now why don't you show how you use this one, okay? This is the one you're used to using. Put your head in front of the sink so you don't spill over, okay? Okay. And blow your nose. Good. And now do the other side. Excellent. And blow your nose. Good job. You did a great job. Excellent. You definitely asked for stickers up front, okay?
You guys have gone through a little bit of a different sequence.
I would say.
You didn't have terrible respiratory infections.
No.
You didn't have anything that you thought was wrong with you. I guess you pretty much thought, well, that's me. That's the way it is.
Yeah, I sort of did.
And you were pretty athletic.
Mm-hmm.
And you play at a pretty high level. What sports do you love to play?
Dance.
You're a dancer.
Yes.
Wonderful. And did you ever wonder why sometimes it was hard for you to breathe?
Not really, but at certain points in time, I sort of did think about it. Sometimes I thought about it more at the pool because you go underwater and, you sort of have to hold your breath.
Right.
So I thought about that.
Couldn't hold it as long as you wanted to.
Yeah.
Had you noticed any issues?
I didn't make them issues. When she nursed, she moved her head occasionally, but I didn't think anything of it and just let it be. So.
And so how did things evolve over time?
She would get very bad sore throats, and and the pediatrician tried real hard to be understanding, but I said, okay, I got to go to an ear, nose, throat doctor, and we ended up with Dr. Bahadori.
And with that, what happened? How did they evaluate her?
Well, he first put a mirror under her nostrils, and one side didn't fog up, and then he scoped her and could, I think this is true, scoped her and was able to see that
Right.
there was a blockage behind her right nostril.
Okay. So she was living her life not really using both sides of her nose.
That's right. That's right. Helen, she had an unusual problem, meaning that the same way we have these two little openings in the front of the nose, you need the same openings in the back of the nose, back here. And on one side, it hadn't formed. There was no opening. There was a bone there, and there was never an opening created. So in a newborn baby, they have to breathe through the nose. It's not like us where we can open up our mouth and breathe through our nose because our voice box is much higher. Mammals usually, the voice box is down here, and in a mammal, the voice box when they're born is up here. So when you open your mouth, you're not getting air into the airway. And as we get older, this descends and goes down, and then we have space to be able to breathe. So in a newborn kid, they have to be able to breathe through the nose. And if they're not able to breathe, it's not compatible with life. So sometimes I have to operate on those kids on the first day or two of life and create little openings for her. But what Helen had was she just had blockage on one side. So it wasn't picked up at birth. She was feeding fine and she grew, and then over time she came in, and what we found with her was that she had this plate here was closed and she had some secretions, and we suctioned those secretions, and then we realized that there is no opening back there, and she's been living like this. And we had to go through the nose with telescopes and drills and drill that bone for her and create a new opening for her, so for her to be able to breathe through both nostrils.
So they call that choanal atresia.
That's called a choanal atresia. And I think with Helen, we also, when we scoped her adenoids, which is number 13 here on this poster, most kids, they can't breathe through the nose because of either allergies causing swelling in the front of the nose, or sometimes their adenoids gets very big, and that caused them to be a mouth breather. And she had adenoids that were enlarged too, and we had to remove her adenoids as well, but she also had that bone plate that we had to repair for her to create an opening.
How old were you when you went through this?
I'm quite sure I was 8 years old.
Yes, you were 8. And you remember being evaluated with a little scope?
Yes, I do.
What was that like?
Well, it was quite painful.
Was it uncomfortable?
Yeah, it's like a sharp piercing pain in the back of your nose.
Oh, because it was so narrow there, nobody could get through to see what they needed to see, I would imagine.
Yes.
How about, did they do the other side too?
Mm-hmm.
Was it as bad on the other side?
No.
No, of course. And we do have a little clip of you using your nasoscope. Tell us a little bit about how that works, the nasoscope.
Sure. The nasal scopes, there's two kinds. One is like a little spaghetti. It's flexible. And one is more like a thin, rigid structure that we put in. And depending on how old the child is and how cooperative they are, we decide which one to use. If I have to use both hands, I would have to use one that's more rigid. So while I'm putting that in the nose, I have my other hand free to suction and take all the secretions out. But if it's a child that I'm just trying to look at the anatomy of the nose or look at their voice box, we use the flexible one that is more like a spaghetti that we could put in the nose to evaluate the anatomy. And usually we try to spray the kids, if they allow us, spray the kids with a little bit of lidocaine in the nose and some neosynephrine to shrink the tissues and numb up the nose. Give that a few minutes and then put the cameras in to take a look and evaluate the anatomy. I'm going to take a look inside your nose first, okay, with a little camera, but I'm going to give you a little spray. This just cleans all the boogers in your nose, okay, so it makes it nice and clean. Let me show it to you, okay. You just spray on this and it's like a little water. You see that? I'll just give you a little tiny spray here. That's all. You did a great job, okay? And let me show you how the camera works. Okay, Mina, if you look at the TV there, this is just a little camera, and if you open your mouth, you can see your teeth. You see your teeth on TV? And there's your ear. And let me put your fingers on TV here. Why don't you put your hand over here? You see your fingers on TV. And then if you give me your hand, you'll see what this feels like. this just tickles a little bit, okay? So when I'm looking in your nose, it feels like it's going through your fingers like that, okay? And that we're just going to tickle the inside of your nose with this, okay? All right. I'm going to ask you a few questions, okay? And you let me know the answers, okay? And then you get a sticker afterwards, okay? Could you first say E for me?
E.
And how old are you now?
6
And how many brothers and sisters do you have?
brothers,
And how old are they?
12 and 14.
Excellent. Good job. You're doing a great job. I'm going to pull this out now, okay? You did a great job. Take a big breath in. Excellent.
right.
Good job.
Girl.
Let me go over the movie that we looked at right now. So we're going to go inside the nose, and we looked on the right side and it was a little bit swollen, so we decided to go on the left side. So this is the midline of the nose. This is the side wall of the nose. We call it turbinate. These are a lot of secretions here that we're going through, and we're going all the way back, all the way back, all the way back, and then we're getting to the adenoid. This is the back of the nose, and this is the opening of the nose from here to down here, and her adenoids are blocking about 50% in the back of the nose, which is about the right size for somebody your age, okay? And since you were such a good girl, I wanted to look at your voice box too, and this is the back wall of the throat, and this is the tongue. This is the back wall of the throat. When we eat food, food goes down here and here and joins in the back and goes down into your stomach. And this is when you say E. You see how your vocal cords, these are your voice box. Okay, that's your voice box and that's your vocal cords, that white thing opening and closing. And when you say E, it comes together, okay? And everything's moving fine. I don't see any irritation, any lesions, or any signs of reflux. Everything looks great. And you did a super job.
So it certainly is a lot better than the old techniques of trying to imagine what you're seeing, putting your fingers back there, using mirrors, things that were really difficult to get a good visualization.
Absolutely. The
with.
technology is outstanding.
I would imagine. You would have really disliked it if you had to go through the old way. Now, they did the procedure, and did they do that in inpatient or outpatient setting?
It was outpatient.
Outpatient setting.
Yeah.
So you knew that it was much like deviated septum, where they really had to break the bone in the
Yeah.
middle of the nose.
Right.
And then, as Dr. Bahadori described, they actually had to drill holes and make
Right.
a passageway there where there wasn't one before.
Right.
And you used a scope to do that as well.
Absolutely.
Yes.
Absolutely.
And in fact, you bought a pretty neat little, I guess, headset, because you can do a certain variety of treatments with the scopes, and you can do them in a very, let's say, a very dangerous area of the head that's so close to the brain and those blood vessels. Tell us a little bit about how you make sure it's a safe way to do it.
So the guidance procedure, I'm not sure if we used this on JP, did we? We did, okay. Anytime I feel that anything's going to be complicated and I have to use my brain a little bit more than normal, I try to have this. First of all, the guy that drew this poster is one of my professors in St. Louis, and he was the first guy in the country that did sinus surgery on kids. So in the late 80s, 90s, we were the only place in the country that was doing sinus surgery on kids. So we had a lot of experience. This technology wasn't there. This does not replace knowing your anatomy and where you are. It's just a double check, because it's not always accurate. But what we do is we put this on the patient in this position, and they get a scan, and then we load that scan to an instrument in the operating room. And at all times when I'm using my instrument, I can tell exactly how close I am to the brain, how close I am to the eye. There's the nerve to the eye, the main arteries to the brain. So we don't, we may think, oh, it's just a simple nose procedure, but we're around a lot of vital structures, and you really need to know your anatomy when you're operating in there.
Yeah, well, as you said before, you have the potential for getting infection just from the spread of one of these sinus or ear infections to the brain, and a serious case of meningitis. So having that guided imagery seems to be just the right thing to be able to do. Did JP have, I guess, the balloon procedure as well? Did he ever have one of
No.
those to open
No,
up
he
his?
didn't have the balloon.
No. So we have another procedure that you do that involves the sinuses, which you do in older kids more or adults?
Adults I've been using in, and there's some studies now, a year and a half, 2 years out, in kids that are promising, which is really the same concept as angioplasty, where the cardiologists go in and dilate the blood vessels. The same way, the whole theory behind the surgery is to make bigger openings. So, for example, for this cheek sinus here, what we do is we go and remove this piece of bone, and we make that opening, the natural opening, 10 to 15 times bigger than its original size. So when they get a cold or they have allergies, there's just more room. The surgery is not a cure for allergies or colds. It's just more room for things to drain so you don't get obstructed and get sinus infections. The theory behind the balloon is we in the operating room, we go in and put a little balloon in there, and then we put water in it, and it dilates, and then it breaks the bone. And we have a little video that we can show later. And it just pushes this bone to the side, and it creates a bigger opening. And we like to use it for the cheek sinuses or the ones up here, the frontal or way in the back. We can use the ones around the eyes called the ethmoids. They're 15, 20 little pockets. You can't really use a balloon for those.
And I guess when you look at this kind of surgery and compare it to the way you used to do sinus surgery, it's quite a remarkable advancement.
Yes, much easier recovery, and patients can go back to work the next day. So for somebody that's not having severe problems, but enough that it's affecting their daily life, that's an option that they can choose instead of the typical opening up the sinuses. Somebody like JP, where he has very thick secretions, that's not an option for him. We need to do the traditional way.
Right. So even still, the procedures you can do with your scope now are vastly different from what they were like when you didn't have those scopes.
Absolutely, absolutely.
Which is a great thing. Your son isn't here with you.
No, he's on a field trip.
He's on a field trip, but he had some pretty interesting issues, and they weren't really related to sinuses. He was basically a pretty healthy kid.
Pretty healthy kid.
Yeah. And tell us a little bit about how you ended up in Dr. Bahadori's office. How did that evolve?
He was having trouble focusing in school and tired all the time. And there was an article in the paper on sleep apnea and the causes of it. And so we went to see Dr. Bahadori, talked to him about his adenoids and tonsils and whether they were too big or not. And so we started down that path then.
And that's what took you in that direction. Were his tonsils too big?
No, they did not look that big.
Okay.
Let me actually first show where the tonsils would be.
Okay.
Okay, for the audience.
Do you want me to come up there and help you with that? You got it?
I could probably hold it.
Okay.
So if we open up our mouth, and that's the uvula, which is in the middle, and the tonsils are to the side. So sometimes they could be small, sometimes they could come and meet in the midline. So that would be a large tonsil. But no, the tonsils were not that big, and the adenoids were not that big with that child, with Harrison.
So you had spent a lot of time working on trying to figure out why you're bright. And wonderful son was really struggling in school.
Right.
You went through a lot of educational evaluations. And
Right.
how did it become clear that there was something else going on that wasn't really related to his ability to learn?
He was tired all the time.
And he complained about that?
Yes. Just even though he went to bed early and got up on time, he complained of being tired a lot. And one thing that really triggered our response was he said that he was afraid to go to bed at night, and he would wake up in the middle of the night gasping for air. And he would want me to lay with him longer during the night.
So it seemed like, well, he's manipulating me.
Yeah,
He's just trying to get out of
that's what we
sleeping
thought at the very
alone,
beginning. Uh-huh.
trying to say, oh, I'm just too tired, that's why I'm not focusing in school. But he was honest with it. He was right. How did you pick that up? How did you evaluate that?
Well, most kids usually between 2 to 8, their head's growing and their tonsils and adenoids are growing. And sometimes their tonsils and adenoids grow a little bit faster than the rate of the head, so there's less space back there. And we have different stages to our sleep. So our deep sleep, stage 4 sleep is when you fall asleep and everything relaxes. So the bigger your tonsils and adenoids are, the more likely they are these things are sort of blocking the airway. So the child goes like this at night, and then goes, and then they wake up. So they get out of that stage 4 sleep to a stage 3, stage 2, or some kids wake up. So they may sleep 8 or 10 or 12 hours, but it's not quality sleep. So the next day when they wake up, they're tired, they don't have the level of energy. It's just like us. We'll be cranky, irritable, and we won't be able to concentrate either. But what was interesting, so a lot of parents bring their kids to me and say, my kids' tonsils are big. I tell them, don't worry about the size. It's really what they do during sleep, okay? Just because they're big doesn't mean they need to come out. It's really how they're breathing and if they're obstructing. But what was interesting is that when I looked at Harrison, his tonsils and adenoids didn't look that big to me. And then the question was how to evaluate it. And we decided to do a sleep study on him to see how, where he goes to a center and they put wires on him and checks his heart rate and oxygen and his level of sleep. And we noticed, no, he is having significant sleep apnea, sleep pauses. And that's when we decided to go ahead and operate. And usually with sleep apnea in kids, we usually take their tonsils and adenoids out. And I was concerned with him that just taking the tonsils and adenoids is not going to do it because they're not that big. Most of the time, I'd say 99.9%, I just take their tonsils and adenoids, they do fine. But on him, there's a procedure where we shrink the tissues inside the nose. So not only do we take the adenoids out, number 13, and then number 8 here, the turbinate, we shrunk it to create, this is erectile tissue that can swell up with allergies, and it's like buying yourself a millimeter or 2 inside the nose. It's sort of like going like this and say, wow, I can breathe a lot better. So we took the tonsils out, and then we also took the uvula, which is that little thing that hangs down in the middle. Basically, I try to take any tissue that I can address without causing significant problems in him to prevent tissues from obstructing his airway while he's sleeping.
So very interesting things you're talking about there. First of all, he didn't have tonsils that looked that
Yes.
terrible, but there were some tissues that were just collapsing when he would relax. And as we know, there's a drive for us to breathe, and certainly you can snore and wake everybody in the house up, but you have a nice continuous breathing pattern, one that doesn't interrupt your sleep. But as soon as you are becoming, let's say, oxygen deficient, you get really driven to wake up. And that's, I guess, really where that deep breath comes, because it takes you to a more voluntary breath. You fall right back to sleep, but you don't get that continuous sleep. You don't get that restful sleep.
Correct.
And consequently, you're walking around tired all the time. Right. So the procedure was done when?
This summer.
This summer. And how's he doing in school this year?
You know, he's getting A's and B's.
A's and B's.
And before the surgery, he didn't want to go to school anymore. You know, he wanted to go to special school to help him learn.
So he felt insecure about his ability to learn.
Yeah, it's night and day difference. And he's got tons of energy and, you know, doing different sports now. So it's been a life changer.
Oh, that's pretty amazing. So he didn't end up needing ADHD medicines.
Right.
Did you ever try those along the way,
too?
too?
Yeah, we did. Tried those medicines, had him with a neurologist, tested his brain, you know, everything. Because you have a child that, you know, is pretty normal and you expect him to do well, and just the struggling was just awful. And so it was as simple as, you know, getting the surgery.
I would imagine it's somewhat hereditary.
You know, it is a little bit. It is a little bit. I don't sleep as well as I should. But he was waking up when we did the study 54 times an hour.
Wow.
So it was a pretty extreme case. And, you know, he wasn't snoring a lot once in a while when he got sick. So it really wasn't apparent. And, you know, going through all the doctors, Dr. Bahadori was the first one, you know, said, hey, let's look at this.
Well, you were fortunate. It worked. It worked.
Yeah, I'm glad it worked.
Yeah.
But I think it's important to also say that every child that has ADHD or, you know, they don't need their tonsils and adenoids out. It's, you know, there's a lot of kids that may need to be on the medicines, and has nothing to do with their sleep.
Sure. And there are some who need both.
Absolutely.
You just don't get pure success with one versus the other all
Right.
the time. But Fortunately, you did in this situation. When we talk about the tonsils, so you were describing how typically when they really are enlarged, it's pretty obvious. You have that garbled voice, that
Correct.
voice that sounds like they have the mouthful of marbles. As
Yeah, they
say.
sound like Darth Vader. Sometimes they walk in your office and they're breathing like that, and the parents say, yeah, I got to shake my child to take a breath, and they just have a hard time breathing. Those are easy. I think with Harrison, it was very, we had to do the sleep study. And sometimes I have the parents videotape the child while they're asleep. Wait an hour or two so they're in their deep sleep, flat on their back, and then videotape them while they're sleeping for about 15, 20 minutes and see if the chest is rising up and down or their pauses there.
And trying to get a little sense, because I'm sure people want to hear what you think about tonsils, and not just those big obstructive ones. Basically, kids get larger tonsils in childhood in response to all those infections that they get. That's the body's basically its first immune introduction to anything that comes in from the outside. So that's where those lymph nodes live, in those tonsils, an immune tissue that helps create antibodies and helps to protect you from getting terribly sick. So they serve a very important purpose, but they get too big sometimes. People also get infections with bacteria that they end up needing antibiotics for. And that's a little bit different. What happens in the situation where they get strep?
So I think most kids end up getting their tonsils out because of sleep disordered breathing, but then we have a subset of kids that keep getting strep. And it's prevalent in school, and they can ping pong it back and forth to each other in a school setting, or the tonsils have these little pockets, little craters, and the strep's deep in the craters. They go on the antibiotics, it takes care of the superficial stuff, then it creeps out again later. And in the old days, the strep used to hit the heart. People got rheumatic heart disease. Fortunately now with the quick strep antibiotics, we don't see that anymore. And really the numbers you're looking for to think about tonsillectomy is 3 a year for 3 years in a row, or 4 to 6 in a year. Those are sort of the ballpark numbers we're looking at. I always tell the parents this: you can still do the antibiotics. It doesn't, just because those are the numbers, it doesn't necessarily mean you have to take the tonsils out. Some kids get really sick, high fever, nausea, vomiting, headaches, rash. Some kids, within 24 hours, are back to normal. So those numbers are just a group of doctors got together and said, okay, these kids are constantly on antibiotics, they're missing school, and you can start thinking about having the tonsils removed. It's much easier as a child than as an adult having the tonsils removed if they're having problems.
Easier to do the surgery and easy to recover.
The surgery is about the same, but the recovery is a lot easier as a child.
Sure. Well, you'll often see families where there will be 2 or 3 strep infections in a year, but it will seem like a lot because the kids get pretty sick, they miss school. Parents are often anxious. They want their kids to be better, to stay well, so they're often prone to think that the tonsillectomy is going to make the difference. When they do get a tonsillectomy and they've had strep a number of times, do you see a significant change in the frequency of infection?
Yes, significant. But what's frustrating is when you take them out and they still get strep. And there's always a handful of those that you see a year, and the question becomes what to do with those patients. But yeah, I'd say 99.5% of the kids, once you take them out, they do get better, and they don't get any more strep infections. But I have had patients who take them out and they still, not as frequent, but they still get it, and it's frustrating. I try to bring them in. Sometimes I put a scope in the nose and see if I can isolate, because we have lymph tissue all over our throat area, see if there's one particular area that's red or irritated that may be the source of the problem. But those are challenging cases, and what to do with them is difficult. If you take the tonsils and adenoids out and they still get sick, but fortunately it's rare.
Yeah, and I think that there was a generation where getting your tonsils out was akin to just becoming a teenager. You had to have had that rite of passage in childhood to be able to move on.
Right. For a while, they used to take everybody's out. Right. Then they went 180 degrees the other way. Nobody had them out. Now we take them out if they have sleep apnea or strep infections.
Right. And people sometimes talk about them growing back. What is that all about?
It shouldn't, if your surgeon's good.
If your surgeon's good. All right. I figured that was the answer. Well, we're not here to talk about your pediatric issues.
No.
But you had a really interesting problem that Dr. Bahadori got involved in.
Yes.
You're a very healthy senior.
Mm-hmm.
and you've been doing pretty well. And give us a little insight as to what brought you in to see Dr. Bahadori.
I was having some tests for my eyes, and at the time I had the test for my eyes, the peripheral vision on the right side of the eye wasn't good. So my doctor asked me to have an MRI, and having the MRI, I found that I had a tumor in my head. And I didn't.
Quite a surprise.
I was surprised.
I would imagine.
And I had a doctor that was there at the hospital at the time, and he told me that I would have to see a neurosurgeon.
Right.
And so we started looking for a neurosurgeon. We found one, and with a neurosurgeon, we also found Dr. Bahadori. So, and got together, and they decided that that tumor had to come out.
And you were with him. Did you have any suspicion that there was anything going on in his head at that time?
Not at all. We had noticed that he'd been gaining weight and he was eating the same things I was eating. And we thought that was a little strange, but we didn't realize until the tumor was discovered that that was contributing to the weight gain.
So, in other words, he was eating what you were wanting to eat. Is that it? He was taking it that way, huh? No, but he was eating more than normal?
No, not at all.
No, okay, but he was
No,
just gaining,
just gaining weight.
He was
and we
gaining
didn't
weight.
know why.
And you're pretty trim, pretty lean.
Mm-hmm, I
And
am.
you stay physically very active,
I do.
as good as you can. That's great. So, what was the diagnosis?
Mr. Perry had a pituitary tumor, which is this gland right here. So if we go straight in, there's a gland right here about the size of a pea, but it's in a very difficult area. It's right up against the brain, and you got the nerves to the eye on both sides, and then you got the main arteries from the body to the brain on either side of that pea-sized gland. And when you have a tumor, it keeps expanding and it puts pressure against the nerves to the eye, so you start losing your vision. And it happens very slowly. As Mr. Perry mentioned, you don't really notice it initially, and it was picked up on an eye exam. And in the old days, we used to make a incision underneath the nose and lift everything up and go back. But with Mr. Perry, what we did is we went through the nose with the scopes again with the neurosurgeon, and we created a big opening to where that mass is, and this is the pituitary gland here, and we drill this bone here, and the neurosurgeon can then go in and take the tumor out all through the openings in the nose. And we had to do this twice on him. We did it once. He was one of the first ones that had it all endoscopically done at Fairfax Hospital. Dr. Milisi that you mentioned and I, we did the very first one at Fairfax Hospital years ago. And we've done a number of these together, but we go in through the nose and try to remove everything through the nose. And the neurosurgeons I show them where the tumor is, where the mass is, and they're in charge of taking the tumor out. And the tumor grew back again. I think 5 or 6 years later, we had to go back and take more out, and the mass was quite large. And at that same time, we had a break in the membrane between the brain and the nose. So suddenly he had all the fluid between the brain leaking through the nose. So the brain fluid was leaking through the nose, and we had anticipated with the mass being so large that we may have something like that. So before we started the procedure, I had harvested some tissue, flap of tissue from the septum, from the midline, and then when we had that leak, I just rotated that up against the brain and closed that area of leakage to close that hole for him, and he's done quite well. He did very well afterwards.
I'm sure he didn't tell you he was going to do that in the first place.
No, he didn't.
No, but I'm sure you were really grateful that he
You
did.
bet I am.
Yeah. And things have gone quite well since then.
Oh, yes. Yeah.
And your nose works fine.
Very good.
Yeah. And the pituitary's an interesting gland just because it's part of the brain and it's close to that blood flow because it makes a number of hormones that really control some of the vital tissues and functions of our body.
Absolutely.
And it is something that usually people will have symptoms associated with a pituitary tumor.
Correct. Well, fortunately, most of the time it's a benign tumor. It's rarely malignant, and usually with females, they may notice their periods are off, or hair loss, weight gain, energy level, all those, vision loss, all those may be affected.
And headaches, are they common when people have those sorts of things?
Not usually. Not usually.
And are you commonly going to use, I guess, that same kind of contraption that you used?
Yes,
with
the
guided-
navigation
Yes.
system. Yes, anytime I need to be outside the norm, I would use that navigation, and it's just an added protection for the patient. Really, you're working in tiger country when you're working back there near the pituitary, and you can't be off a millimeter or two. So we use that navigation system to make sure we don't do any damage to the nerves, to the eye, or the brain.
And when you start to work with that part of the, I guess when you do that kind of procedure, you need to stay as an inpatient just to watch for any spinal fluid leaks or anything of that
Correct.
nature for a few days. So as opposed to just about everything else that you do, which is in the outpatient arena, that's one of those things that you probably have to be a little more careful with.
Absolutely,
And
yes.
keep there. And I know also with your scopes, you are able to get down and actually see down the other way, and that's a whole nother realm of the work that you do that we really won't have time to talk about. But that scope can look up, it can also look down.
Absolutely, yeah.
And you look at all the structures down there.
We can look at the voice box and see why the kids are hoarse, check for reflux, irritation, any growths, lesions, any issues in the throat area.
Phenomenal. And of course, I thank you all for being here. You guys have great stories. It was wonderful talking with you. And Dr. Bahadori, who I trust all of my patients with whenever I have an issue, of course, over the years. That's why he's here, of course, and thank God he is. He does great work. And of course, to all of you watching us, I do want to thank you for being patient and seeing some of the video that we add into the show tonight. Remember, until the next time, I'm Dr. Russell Libby, looking out for your health.